Our today's lecture is on the motion management for radiation therapy. Unfortunately, Dr. Lu was not able to make it today. He got sick, so Pьотr graciously offered to do his lecture first. So I think it would be very, very interesting for all, especially for our Ukrainian colleagues, as motion management is not widely implemented there. So our great speaker today is Pьотр Dubrovський, who is the Canadian-trained medical physicist with Polish and Ukrainian roots. Pьotr is a medical physicist at South Bay Satellite of Stanford Radiation Oncology, and throughout his career, he had the opportunity to bring several new cancer clinics operational from ground up. He's really a well-rounded, great clinical medical physicist and a great example for us all. He was recently promoted to Associate Quality Director of Physics, responsible for improving patient safety and workflow technology improvements across a wide cancer care network. So congratulations, Pьotr. And Piotr's research interests focus mainly on improving treatment planning process, increasing safety. He is working tirelessly on improving our auto planning check, adding more checklists to it. He's also very active in a 3D printing area. And Pьотr also is giving back to the global community by helping out cancer centers in Africa, Tanzania, and Kenya, and giving lectures and visiting there as part of the global program here at Stanford, and also Rise Contra Cancer Group. But today his talk is on motion managing strategies in radiation oncology, imported for radiotherapy treatment of moving targets such that in lung, GI, breast. So we are very eager to hear you talk. And thank you again for stepping up and offering to do this lecture on short notice. So I will stop sharing. Take it away, Pьотr.
So thank you, Natalia, for the very, very nice introduction. Share. I assume you can see my screen. And it's very appropriate that I'm taking Bill Lu's spot, because a lot of these slides are actually from old Bill Lu talks. So it's very fitting. And this was me last night trying to stitch together several old motion management lectures. So apologize, it's a little bit rough and ready, but hopefully we can all kind of learn something. So just outline of the talk. Again, we'll just talk about motions in radiation therapy and the motivation for why to manage them. The bulk of the talk will be about respiratory motion, because that's sort of the most important and kind of the largest motion and most difficult to manage. So I'll break it down into simulation and treatment paradigms. And I'm going to break it up into free breathing, like the patient's free breathing and the patient's in a breath hold. And then I'll go over some other motion management systems that are kind of emerging, or some of the changes that are going to be coming along. So obviously, why is motion management important? So radiation therapy is often given over multiple daily fractions. So it's almost never given in one single go. And our treatment machines currently cannot fully adjust for the daily variation of a patient. So we start with a simulation, which is just a quick snapshot of a patient, and all our future treatments are planned on this. And so we have to use a combination of planning, technology, and target margins to compensate for all these potential motions that the patient can experience during their treatment. So it's a really interesting time for us. So technology is beginning to change all this. So it's curious to see what the future will look like with regards to truly adaptive therapies like V-Ray or Ethos coming online, real-time tracking, and hypofractionated treatments becoming more and more ubiquitous. So it's interesting how motion management will kind of change as we move to the future. So very simple. You've seen many of these slides in the previous talks that Natalia has organized. So external motion is very common, and we generally, as a field, have a very good grasp on how to eliminate external motion. So obviously, we minimize motion, patient motion, through devices and through comfort. So these are things like the vac bags, thermoplastic shells that the just have talked about in the previous lectures. When you move into the SRS, SBRT, kind of hypofractionated treatments, we tend to think of increasing the degree of immobilization because we want to reduce our margins and increase our doses. But interestingly enough, when I first came to Stanford's approach was a little bit different. They wanted to exploit technology, speed, and comfort versus increasing the immobilization of a patient. So there's many ways to kind of approach this problem. But external motions are generally pretty easy to manage. So what about internal motions? So again, outside of respiratory motion, which we'll talk about in a second, anatomical variation is pretty common. So things like bladder, stomach, bowel, and the rectum all can change quite drastically day to day. And so how do you manage those? Well, kind of generally speaking, you can think about internally immobilizing the patient through general patient information and things like controlled bladder filling, bladder voiding, scheduled voiding. We've recently started using, ultrasound bladder scanner here at South Bay for our bladder patients to make sure that they're filled enough for treatment. You can use the same thing with rectal voiding enema and diet. So, NPO orders or even diet changes to limit gas and things like that. So this is a little bit more challenging and it's not insignificant in terms of patient outcomes. So this is like a very old clinical trial that first moved from kind of 2D planning into 3D CT-based treatments. This is again 3D technology, quite old slide, but it goes to show you that if they didn't compensate for, or if they didn't compensate for a distended rectum on that CT scan, and they planned with it as it was, the patient had 30% lower biochemical control, which is huge just by not accounting for the air in the rectum. You can see that patients were drastically affected. So it's very important motion kind of strategy. It's less of what we think of as respiratory motion, but or motion management, but it is very important and it has a huge clinical impact. But really the bulk of this talk is going to be about respiration. So basically anywhere that we treat near the lung, especially lower thorax, upper abdomen, there is very large motion. So I really like this schematic. On the left-hand side, you have about, I think it's about 30 patients that this group kind of tracked on during a 4D scan, the motion of the tumors. So you can see they categorize them as, red is the kind of highest motion, and then black is the lowest motion. So just in a single or a 4D scan, you can see there's lots of motions, and it's very kind of diverse. Sometimes there's lots of motions, low down, sometimes there's less. So it's very specific to the patient and specific to the location. And likewise, on the right-hand side, these are intrafraction changes. So taking all these different scans, you can see that not only are the tumors moving moment to moment, but also in between fractions, there's pretty systematic and random variance in the way the patients breathe. So all that is to say, it's a pretty complex problem and it requires lots of solutions. So this is also another slide showing that depending on where you are in the lung, you can have very drastic motions. So not one solution is going to work for all patients. It has to be driven by patient-centric and location specific. So I'm going to kind of approach this talk in kind of going from simple to most complex. And there's different motion management strategies. So very simple is motion encompassing. Next, you can kind of get patients to hold their breath and freeze the motion that way. Forced shallow breathing with some sort of device. Respiratory gating starts to become a little bit more complex because now there's like technology involved, and there's many others to kind of talk about. And again, these kind of go from quite easy to implement to quite difficult. I like to think again of kind of separating these into two groups, and I like to think of it how the patient's breathing. So if the patient's in free breathing, this includes motion inclusive treatments and respiratory gating. And then for the patients in the breath hold. And ultimately, again, why are we doing this? It's in order to reduce the margins that we need to ensure the patients are treated safely. So this is a really kind of, not a simulation, but it's a calculated margins for the different motions that a patient can have. And depending on what kind of motion management strategy, you can drastically see how much you can reduce margins in order to achieve, a good coverage. So again, if you have no motion management, you need very large target volumes or target margins. The moment you add a 4D CT, which gives you the idea or gives you the information on how the patient's breathing, you can start to reduce that margin. If you then move the respiratory management into the delivery of the patient, you can actually start to reduce the margins further. And then if you finally start to beam gate, you can actually reduce quite a lot. So all this is to say that depending on what kind of motion management strategy you have, that's how you have to apply the entire strategy across the entire workflow, and it must be reflected in the margins. Okay, so looking at simulation, this is where all of motion management begins. You have several options on the CT scanner. The easiest and sort of the most common is a free breathing scan. Obviously, these are nice high quality images, have contrast in them. So these are nice, high quality images, but you have almost no motion information in that scan. Next is what we'll kind of talk about. It's called a 4D CT. So this can capture the full motion of the patient and full respiratory motion. There is a couple downsides. One is there's obviously increased scanning dose. There's often limitations on how spatially how fine the resolution can be on these scans, and there's often a lot of reconstruction artifacts. And finally, a breath hold CT can is trying to merge the two worlds. Obviously, it's just a normal CT scan, so you get that high quality information or quite quality image, and it can freeze the motion by voluntarily asking the patient to pause. However, obviously, not all patients are eligible for breath hold CT scan. So how do we assess, or how do we track the patient's breathing motion in order to generate these different scans? So this is a very old slide, so I'm really sorry. This is no longer how any of these systems look like, but the idea is the same. So this is called an RPM system, or respiratory patient management system from Varian. I think it's the most ubiquitous one. Essentially, you have a block with some infrared dots on it. You have a camera that has an infrared array on it and a simple camera. And you place the block on the patient's abdomen or chest. And as the patient breathes up and down, the location in the CCD camera of these pixels gets recorded per time, and you can then basically map out a respiratory trace. You can take this trace then, and you can give it to the CT scanner, and then it will use it to reconstruct 4D CT, which is basically here. So let's say that you have a patient scan. This is the patient's respiratory breathing trace. The patient's inhaling here, exhaling here. When the CT scan is on the first bed position, it continuously is capturing images at that scan. So it doesn't move very quickly. It waits for the patient to have a full breathing cycle. And as the patient breathes, it acquires continuously CT scans and tags them with the corresponding location in the breathing cycle of this patient. Once a full breathing cycle has passed, it can then move to the next position. And it does the same thing where it attaches or tags the location or the phase of the breathing cycle onto these images. And it does that across the entire patient in multiple bed positions. So that's an axial acquisition. So now you can basically take the different the different respiratory the different images, different slices of tagged of the respiratory phase, and stitch them into the corresponding table positions to create a full 3D image of that phase. So be it the 50% or so. And essentially that can give you a full 3D data set that's binned in time, or what we call phases. So effectively the 0 phase by convention is your inhale phase, and your 50% is your exhale phase. And so you have, this is again, a full 3D data set binned in time. So that's the 4D aspect of it. So patients are very regular breathers, and they're, you can get a very nice movie, 4D data set like this. So this one actually has a little bit of artifacts. But if a patient is kind of non-compliant or is an irregular breather, without coaching, the 4D data set can look something like this. So as you can appreciate, there's lots of artifacts here, and it's not very useful. So one of the biggest caveats for 4D CTs is that there are always artifacts, almost always there are artifacts present. They can look at it like this, where things are blurred due to motion. There's additional slices or overlapping slices or kind of incomplete slices. And effectively, this is due to those binning artifacts where the patient, if they stop breathing, there's no information there, or the patient took a really big breath followed by a really small breath, there's overlapping data. And so when the 4D CT starts to rebin and reshuffle all those slices, it can basically place them in the wrong phases. There's a little bit of work that we can do to fix them, but in general, if a patient just didn't breathe and there's missing information, you'll never be able to fix that slice. So the one kind of caveat I want to stress is that 4D errors can sometimes be not obvious. They can be pretty subtle, but they can have a huge impact on planning and delivery, because these will get transferred to the physician for contouring and get transferred to the delivery system. So it's very important to do a patient assessment, make sure patients kind of understand what they're expected to do, that they're compliant, and that they're well coached, that have a conversation with the patient before this, just to set expectations to get the best outcome. And often, especially in sort of, older technology, the retrospective 4D binning can take a long time. So we used to have a very old scanner that would take literally most of the day to the process. So we would do them all at the end of the night. So you wouldn't know until the end of the day if your CT scan, your 4D CT scan was accurate or was good. So this is the first poll question. I hope someone has the poll. There we go. So thinking about what a 4D CT samples during the patient's respiratory duration. So what is the 4D sampling? Is it the entire treatment course? Is it sampling a single treatment simulation session? Is it sampling about like 2 minutes of a patient's breathing? Or is it one breathing cycle? Oh, interesting. Yeah. So actually the answer is D. So if you, so if you think about it, really, you're just sampling the patient's breathing cycle, because that's the spot where the CT scanner sits in one position over the patient's breathing cycle, and then it'll move on to the next one. So not only is it just one breathing cycle, but it's one breathing cycle per bed position. And then that's out of the entire patient's lifetime, and they may never repeat that same breathing again. So you have to, even though we tend to use 4D ubiquitously for motion management, you always have to take it as a grain of salt. You can't trust it 100%. Not only are there artifacts, but again, this is just a very small sampling window of the patient's respiratory kind of phase or respiratory breathing. The second question is roughly what prevalence of artifacts are found in cone beam CT, 4D CTs, excuse me. Is it 15%, 30, 60, or 90? Again, as technology gets better, this number is probably getting lower, but the number that I was able to find was not this point. So the answer is actually 90. So 90% of all CT scans have some sort of, 4D CT scans have some sort of motion artifact or reconstruction artifact. So it's pretty common to see these. They can be pretty minor, or they can be just absolutely not usable. So again, these two questions, I want to highlight the fact that if you do kind of have a 4D CT, you always have to be very, very attentive to what you're looking at, how you're contouring it, and not to trust the technology completely. So I kind of talked about how we can capture a 4D scan and we can rebin it to have basically data sets that are kind of spots in time, and we can use these phases from 0 to 90. But we could actually take that same data and recombine it into a different way. So often you'll hear something called a maximum intensity pixel map, or MIP, minimum intensity minute, or an average IT. So essentially, these are just reconstructions using all that same data captured throughout that 4D CT. The maximum intensity pixel one will basically, sounds what it does is it'll take out of all those locations, out of the same locations across time, it'll take the maximum pixel intensity and place it into one single data set. So effectively, this means that the brightest pixel across any phase gets added to this data set. The minimum intensity pixel map is the opposite of that, takes the minimum. And the average, obviously, is an average. So everything kind of gets blurred out for that set. So in these cases, you only have one set and they have different meanings, but they're not real. So one thing you have to be careful when you're looking at these is they're not actually the patient anatomy. They're just kind of reconstructions and different ways of reconstructing it. And I'll talk about when they're useful in a little bit. Okay, so moving to free breathing delivery and planning. So now that we have some sort of captured movie with this 4D, let's look at treating the patient with the patient's free breathing. So in terms of the patient's motion, they're just breathing naturally, and we will do things on our end for delivery and planning. So sort of the easiest is motion inclusive, ITV. So in this case, this is a movie of the 90 phase, or excuse me, the 10 phases of a patient. You can see the tumor moving up and down. And we will simply draw out a motion inclusive ITV. So I think this has been presented in the past, but just as a reminder, an ITV is, we're very familiar with the GTV, CTV, and PTV, these kind of targets that we grow and these margins that we add on. So the ICRU recommends basically putting another margin between the GTV and the PTV called an ITV. So this is an expansion on your CTV to account for any internal motion that you have information about. So in our case, this would be the lung tumor moving around. So this is my very poorly drawn ITV. And again, you can see that as the tumor moves, it is completely encompassed by this ITV that we'll be treating. So the beam in this case would be on, oh, sorry, jumping ahead. So essentially to create my ITV, I would use all the phases of my 4D CT scan. So phases 0 through 90. However, I can use one of those MIPs. So essentially a MIP shows you the entire range of motion for that tumor in a lung tumor in this case. So any pixel that's blurred out in a MIP will be where the motion of that tumor is within the lung. So I could just contour the entire MIP area of that tumor, and it should correspond fairly well to an ITV across all those phases of the 4D scan. Or if you don't have the technology of a 4D scan, you can actually do slow CT scans. So this is something that we've done in the past, but you know, having worked in a few kind of low to middle income countries, this is something that can still be done where you slow your CT scan down to capture one image per breathing trace, and then you move on to the next one. But instead of rebinning it, you're just kind of letting the motion blur. And anywhere you see motion, that's your ITV. So it's quite low tech, but it works well, it's quite effective. So often there's a question about, now that I have my motion inclusive ITV, and I have all these different scans, I could have an exhale scan or a 50% phase, or an average CT or a MIP. How do I know which one do I do the dose calculation on? This is a kind of a tricky question. And you have to balance image quality. You have to be able to see what you're going to be calculating to and be able to contour on it and make sure that your dose is well, you know, you have the spatial resolution for good dose calculation. And it has to be representative anatomy. So using a MIP is not going to be representative because that's not a real anatomy. It's just a reconstruction. So you have to be very careful with when you're doing the actual dose calculation, which CT scan you're going to choose. So for delivery of a motion inclusive treatment is very, very, it's nice and fast and easy. So the pros are, it's quick. The beam doesn't stop. It's basically treating the entire time. The target is the entire motion of the tumor. Very easy for the patient and quite easy for the RTTs, so they love it. It's great for when motions are quite small because your ITVs can be pretty limited. And the nice thing is, again, it doesn't need actual gating capability on the LINAC. You could use this on any LINAC, but you know, it doesn't need any sort of RPM system. This is how it was done, kind of, you know, some time ago. And it was all your motion is captured in the treatment planning phase, so you're not actually gating anything on the machine. If you do have an RPM system or some sort of motion management system that can gate your beam, it's quite nice to actually put some gating parameters on your breathing trace, but have them wide enough that the patient's just constantly being delivered. And if they take a big breath, or if they cough, or if they get up off the table, the beam will be held. So again, those are the pros. The cons is if there's a large treatment, you're going to be treating a larger volume than you need to, because you're encompassing the entire motion of the tumor or of the target. And as a result, if you have OARs and you are close by, you're going to increase the dose of those OARs. So can we do better? Oh, sorry, this is an example of, again, very old slide from Bill Liu, looking at the entire time, the beam is on the entire time the tumor's in motion. So can we do a little bit better with gating? So contrasting this to our motion inclusive ITV, you can see that the patient, or most people, have kind of a pause in their breathing. Usually this is between like the phases 30 and 70, where their motion, the tumor is actually pretty minimal. So can we exploit that and use what we call gated ITV? So in this case, instead of capturing the entire motion of the tumor the target in our ITV, let's only envelop the 30 to 70 phase as the 4D CT determined. So you can see there's very little motion here between these phases. So maybe we can just target these phases and then turn the beam off when the tumor moves out of the way. So this is an example of how that's done. So you can see the beam is on and off just when the tumor enters our kind of predetermined target. But obviously this needs a little bit more technological process. So in this case, you absolutely need a 4D, because you have to evaluate the motion of that tumor relative to its phases and determine appropriate phases to create your ITV on. Commonly, this is around exhale, because we spend, like, naturally, we kind of pause during our exhale. So it's a very nice area to target. But we've seen other phases, maybe an inhale, or for whatever reason. It's very rare, but most of the time we're in an exhale. Again, which dose, which CT do we calculate on? Again, you have to kind of balance your image quality of your 4D and the representative position that you're going to be doing. And then very important question is, how do you deliver this? So we're very variant-centric at Stanford. So this would be a very variant kind of terminology, but I think it's a pretty standard. So there's two delivery types that you can deliver on a machine. It's called amplitude or phase-based gating. And there's a lot of pros and cons to each. So I'll just kind of go through it. So phase-based is a little bit more simple to think about. And it's basically, you're looking at the rhythm of the patient. Okay, so again, this is the patient's breathing trace as they breathe. You're going to assign, again, directly from the CT scanner 4D, we're going to assign treatment during the 30, 40, 50, 60, and 70% phases, which would look something like this. The blue bars indicate the beam on of the machine based on the patient's kind of breathing trace or calculated phase. So one thing to note is when we say phase, the phase is calculated basically from the rhythm of the patient's breathing, but it's always influenced by the past breathing cycle, because you don't know what the next one's going to look like. You can't predict very well what the patient's going to do. So it's kind of a lagging measure. So it's always influenced by the couple of last breaths. So if the patient's very rhythmic, it's an excellent delivery technique. So let's say the patient is still very rhythmic. So you can see the period of the breathing is very similar. But what if they do this strange thing where they kind of don't take a huge breath and then they don't exhale far enough? Well, phase-based gating, it really only cares about the rhythm of the patient. So in this case, it would generally beam on during the same rhythm of the breathing cycle. So again, phase-based, it matches the patient's respiratory rhythm to a cyclic rhythm. It's kind of a lagging value, so it's always calculated from the previous breathing. So it's influenced by the previous breathing breaths. The nice thing about it is it's quite simple and fast. So we usually use it for patients with like a large number of fractions, because it's pretty quick to deliver. The con is that it's pretty insensitive, like I showed you, to if the patient starts to change the motion of their breathing, not so much their rhythm, but their amplitude. It's kind of not robust to that. And also it is always influenced by the past couple of breathing cycles. So you might need to account for that additional kind of insensitivity in your margins and in your plan. So the counter to that is something we call amplitude-based treatment gating. So in this case, you're not looking at the rhythm of the patient, but you're looking at the absolute position of this block. So if the block is up here, once it dips below a certain threshold, this upper blue part and the lower red part, orange part, once it's in there, it'll beam on. The moment the patient breathes out of it, they'll turn off, it'll breathe on again. So again, if you look at our irregular patient that was kind of started to do something strange, again, the beam will only trigger when the patient's within this physical amplitude. And so you can see that it kind of is a little bit more robust to erratic breathing. So it uses, again, amplitude-based is a little bit different. It uses amplitude of the marker, not the rhythm. It's a little bit more robust against kind of erratic motions. So we tend to use it for SBRT or any sort of treatments that require that precision. But the con is that you have to convert the 4D CT phase-derived target, right? So the 4D CT lives in phase world. And now you have to convert it to an amplitude. So the two aren't correlated. So you have to correlate them somehow. And that's through the use of IGRT to evaluate what those thresholds should be and what they mean. So this is why we only do it, or we tend to do it for kind of SBRTs, where we need that precision and it's a low number of fractions. So, you know, daily kind of additional IGRT steps aren't that intrusive there to the clinic. So one cautious, so far we've kind of been talking about, you know, basing everything on this respiratory signal, which is really as just a surrogate for internal motion. And it's not perfect by any stance, but it's kind of the best we have. So you know, we make it work. This is a nice little schematic of a patient, single patient, over, I think, 20, 30 fractions. And you can see the respiratory breath cycle, or the respiratory trace, is quite varied. Sometimes it's large motion, sometimes it's little, sometimes it's in an absolute position here, sometimes it's there. Likewise, from the variant handbook, they kind of go over and discuss the different ways patients can change their breathing and kind of, you know, and give difficulty to the RPM system. So again, if patients aren't consistent with their breathing amplitudes or their breathing rhythm, sometimes patients kind of drift up and down slowly. There's this baseline drift. So all that can cause the RPM system, you know, issues with predicting and gating the beam in an effective way. But ultimately, even, you know, the correlation between the marker on the patient's surface and the internal anatomy can sometimes break down pretty drastically too. And so here you see the pink lines are your internal marker, so your actual internal anatomy, whereas your external RPM block can be consistent. The internal anatomy can drift, it can change in amplitude quite drastically. So all this is to say that you do need some sort of visual verification of what you're doing, because you need to correlate those two systems together. So we love to stress this, that gating is really not a science strictly, but there's an art to it. And it comes with experience, it comes with, you know, again, basically experience and time. So very important to have very good patient assessments, play a role in the coaching of a patient, set them up for that best 4D treatment that they can receive, and compliance. So if you have a difficult patient, maybe 4D is just, or maybe motion management, especially gating motion management, is not appropriate. So how we do our gating verification is we'll basically take initial KVs and we'll align them to their bony anatomy. And usually these are triggered, so it's very nice. The variant system, because it's all one system, can trigger both the KV system and the MV system. So we can use the RPM to trigger our KVs. So ideally, this is in the same, you know, motion management position as we would be using for treatment. We'll then take a gated cone beam. Again, we can actually trigger the acquisition of the gating of the cone beam to be only within whatever gating parameters we set, whether that be phase-based or amplitude-based. So essentially, we'll reconstruct a cone beam on the machine, exactly what we would be treating. So any blurring, any motion should be representative of any motion, residual motion that we have within that machine. So we can then align our anatomy evaluate if our margins are good, do pitch and roll corrections at that point. And then finally, we'll also kind of often do just a like a fluoroscopy acquisition in order to verify our thresholds. So I have a couple examples here. So again, this is a patient's fluid breathing here. You can see their trace. So they breathe in, they exhale, and then you can see that the target kind of changes color when the beam's on versus off. This patient has fiducials or a very solid tumor, so you can see it quite well. What happens if we don't see anything? Well, you can use another surrogate. So it's like a surrogate on top of a surrogate, I guess, with the diaphragm. So from this projection, we can contour diaphragm and we can watch to see if the diaphragm aligns fairly well, given our thresholds that we've determined for the gating. So the variant system also has intrafraction verification by imaging. So it's quite nice. So while the beam is actually delivering radiation, we can take triggered images, which we can use to verify that, just even though if we did everything perfectly during the IGRT portion, during delivery, this gives us one more step where we can verify that when the beam turns on, this is kind of denoted by the yellow the bars here. The beam turns on, it'll acquire another image, and if you look closely, you can actually see the outline of this tumor, this case, or you can trace the diaphragm as well. So this gives us, again, another verification step to make sure that what we're setting for the RPM system is actually, in fact, putting our target where we want it. So I think this is the last couple full questions. So when talking about an ITV, what is false in one of these statements? So the ITV is the expansion of the CTV to account for internal margin and motion. The ITV for an organ is referred to as a PRV. Actually, don't think I mentioned that. Sorry about that. A liver motion inclusive ITV could be approximated using the 50% phase from a 4D CT. A lung motion inclusive ITV can be approximated by using a MIP 4D reconstruction. So this one's a bit tricky. So yeah, basically the answer is D. Oh, excuse me, C, my bad. So basically the ITV is an expansion of the CTV. This is a little tricky. Often physicians will expand the GTV first and then expand the CTV from what they call an IGTV. So that's maybe strictly not true, but it is common. The ITV of an organ is called a PRV or planning. And then this is basically the liver motion inclusive ITV. So motion inclusive means it's going to include all of the motion. Well, if you only look at the 50% phase of a 4D, you're only looking at a very small slice, a very small time point in the entire motion of that target. So the false is C. Again, another false. So this is about phased gating delivery. So what is not true about here? So you might need to account for planning and margins. Phase-based gating is quick and simple delivery. The phase calculation is a lagging value, and it's always calculated from the previous breathing cycle. Or phase-based gating is robust against erratic motion. So the answer is, sorry, I jumped the gun. D. Yeah, very good. So phase-based gating is the quicker and the simpler of the two delivery methods, at least for variant Linacs. But it is not quite robust against erratic motion. So because it's simple and quick, it doesn't really hold the beam as much as it probably should. So it's a little bit more forgiving of kind of erratic patient breathing. So that's why it's quick and simple. But again, for treatments that are spread out over many fractions and don't require that amount of precision, it's a great delivery technique, and it still buys you a huge reduction in margins. Okay, so a little bit about breath holds. So breath holds are, I kind of mentioned, instead of gating the beam, or instead of living with the patient in free breathing where a lot of motion is blurred, well, why don't we just ask the patient to hold their breath and physically eliminate the motion, the internal motion. So at simulation, it's very important that coaching and assessment are done properly because not all patients are eligible, right? Breath hold treatments are kind of great because they have so many advantages, but they're not all patients can do them. So we at Stanford have kind of developed a little bit of an assessment criteria that is done at the simulation before the patient's scanned. And again, we want to make sure they can hold their breath. We kind of go around 15 to 20 seconds or longer, ideally. And again, that's to make sure that we can deliver a significant amount of dose before the patient needs to breathe again. Otherwise, treatments will just take too long and they're too difficult to set up. You can give patients oxygen to improve their breath holds. There should be some change in their breath hold amplitude. So in this case, you can see the patient's breathing here on your right-hand side, and then there's a nice large inhale breath hold, so that it's much different from here. So the machine can trigger off of this beam or off of this amplitude. We often do exhale breath hold scans as well. And so in this case, you want to make sure that when the patient breathes out, that they kind of land at the 0 point of their breathing or at that 50% phase. Again, they shouldn't kind of dip too far because that just makes gating quite difficult. A lot of the time patients have, they're not very stable. So they'll breathe in, you can see a little bit of an example here. They'll breathe in and then they kind of seep out over time. And again, you just can't gate off that because you don't know where in the, they're just basically not stable. And then ideally, all these three things should be reproducible. So because the patient's going to have to do this several times during treatment, you want to make sure that this is very repetitive and comfortable for the patient. One caveat again is, again, this kind of art versus science, it's quite difficult or quite important to find a nice suitable spot to put the RPM block on the patient. Each patient can be slightly different. So some patients are chest breathers where their chest has a lot of amplitude, especially during a breath hold. Some patients are belly breathers. Most of that amplitude is going to be in the belly. So the therapists at the CT simulation or whoever's there needs to really assess the patient, figure out exactly for each patient, not only can they do the breath hold, but where do I put this RPM block to give me the best signal that I can to base everything on, and then clearly communicate this to the team. So let's say, how do we verify when the patient comes back for treatment? How do we verify that the breath hold is what we planned on? So again, we do a lot of this, either image the actual tumor, or in this case, we're going to be imaging the diaphragm of the patient, and we're going to coach the patient to breathe in more or out a little bit in order to match the diaphragm as best as we can in this case. So on this example, you can see there is no gating, like the thresholds are quite wide. And once we've determined that, we can then tighten the thresholds and we can verify through either triggered imaging or some other means that when the patient enters this threshold, the beam will turn on and it's the diaphragm will be in the right position. So that confirms to us the selection of our threshold for the breath hold. Varian has recently released this thing called a biofeedback breath hold system, or VCD, actually a visual coaching device. At Stanford, we had built one kind of ourselves, but essentially they look like this, where the patient actually sees their own breathing trace as a vertical line, and then the other line here is the target that we set for them. So simply the patient breathes in until this line and this line overlap, and that means they're in that breath hold target that we set for them. And then we can, do some IGRT to verify that their internal anatomy looks good. And if not, we can adjust. So this is definitely a cyclical thing that we do, and often can take a few attempts at to get a good agreement. Again, I mentioned oxygenation is quite important, so you can give patients oxygen. We don't tend to do it that often. I think Palo Alto Clinic does a little bit more. And so we tend to not do that unless the patients are really struggling. But you can give oxygen to patients to improve their breath hold. So again, a kind of clinical process for IGRT breath holds. Again, we'll start with KVs. Ideally, they're triggered by the KV system, by the respiratory system, so that they're in already a breath hold state. We will actually do some fluoroscopy, like I showed you in the last couple images, to make sure that the alignment of some fiducial or some marker lines up with that breath hold. And if not, we'll change that breath hold to get the patient into alignment. And then finally, we'll do a gated breath hold cone beam CT. So again, this is patients holding their breath while we're acquiring that cone beam. So ideally, any motion that you see should just be residual motion at that point, and small tweaks, or you can tighten up your gated windows at that point. So there's a few caveats. One, about using that VCD system. So a lot of different motion management systems now come with these like goggles or screens. It's very, some patients kind of inadvertently, just by accident, realize that they can manipulate that bar with their abdomen rather than with their lung volume. So patients will kind of stick their abdomen out rather than actually inflating or deflating their volume. And so they basically trick the RPM system. And often this can be really, really difficult to figure out what's happening and why the patient's anatomy isn't lining up to their breath hold. So it's quite difficult, but with lots of coaching and kind of explanation, patients are pretty good. And the other kind of important aspect of breath hold scans or using breath hold treatments is that if you're going to match any sort of subsequent imaging to it, it's quite difficult and you have to break the imaging, right? So you're planning CTs and a big breath hold, but the PET or the MRI that you're trying to fuse to it is probably going to be in free breathing. And so it becomes very difficult to match those two, especially around the diaphragm. If you're interested in multiple things, it can be quite challenging. And this can cause some issues with incorrect contouring. So all of that I've said to this point is kind of most achievable breath hold treatments for things like lung or SABR. So breast is a little bit special. We do a lot of our left-sided breasts, or almost all our left-sided breasts, in a breath hold to separate the heart and the breast to kind of lower cardiac doses, which is very important. But it's a simpler approach. Effectively, we don't do all that imaging that I just recently talked about. We just simply will align the patient like we normally do with setup marks, SSDs, and shifts, and then we will do initial KV or an MV imaging. Again, it's triggered by the breath hold that we determine. We'll evaluate the lung and the chest wall alignment and the field borders. So we'll basically align, our expected chest wall versus where it is, breast contour. And so it's a little bit simpler. On days where we're not imaging, we will still use the breath hold from the RPM system, so the previous established breath holds. So that's why it's really important to consistently place that block in the same spot. So if you placed it one day on the chest and one day on the abdomen, you might be coaching the patient into very incorrect breath hold status and move their anatomy out of the way. So the one thing about breast and breath hold is that it doesn't need to have a very high-tech solution, right? So most of our machines have our full RPM systems or our GOC systems on them, so we utilize that. But there's been many studies or many suggestions about using kind of lower tech solutions. So in this very small paper I found was, the CT, they had no RPM on the CT, so they just had asked the patient to do a voluntary unguided breath hold, so just comfortable breath hold. They assessed whether the heart kind of had enough clearance, and if so, they proceeded to treatment or planning and then treatment. So during the treatment, they actually just used imaging, so an EBID MV imager, to reproduce the chest wall lung inhalation volume that they saw from CTs, or like what we do now. But instead of having like a full RPM system, they literally on the video camera screen in the room, they were monitoring the distance between the lateral tattoo and the wall laser. And we actually did something similar here on one of our centers when the RPM system was down. We just basically had a laser shining on a box on a patient, and we would mark it on the screen where it was. And so as long as you're IGRTing it, as long as you're seeing what you want to treat, and you're monitoring the patient's level in whatever, whether it's high-tech or low-tech solution, it's pretty achievable. And these guys correlated the use of these kind of lower tech solutions to the RPM system, and they found that they're very, they agree very well in terms of lining the patients up. One of our ex-residents, who's now at San Francisco, actually developed an iPhone app where you place your iPhone on this little stage, the stage attaches, or not attaches, but rests on the patient's chest. And as you breathe up and down, the phone moves up and down, and the gyroscopic data from the phone can get converted into, an RPM trace. So you don't, the nice thing about breath holds and for breast is that you don't need these high-tech solutions. You can actually kind of think outside the box a little bit, still do it quite safely. Again, as long as you're performing all the necessary imaging to make sure that you're lined up well. Okay, so the last 10 minutes, I'm going to try and fly through a few, I'm going to talk about, so there's different ways. Again, the ABC system from Lecta is very similar, but it's a little bit more invasive, where patients are actually breathing through a spirometer. There's bellows or belts that can measure how much your head of belly is expanding in order to get a respiratory trace. There's a little range finder, like a laser, that kind of determines the distance. And again, it measures how the patient's breathing up and down. But maybe you don't need anything at all. So there's lots of centers that achieve respiratory motion management through just abdominal compression, or even these kind of vacuum sealed devices. And effectively, these are great if they can reduce the motion down to something that's fairly small, and then you use a motion inclusive ITV on top of that. You can get very good reduction in margin, and you can treat infrared breathing without gating altogether. We found that this does tend to reduce patient comfort. So, patients can inadvertently increase and move and kind of get non-compliant. So this might kind of work against what you're trying to achieve. And in planning, it could be a little bit difficult to avoid these devices. You have to be careful of collisions and things like that. So, but it's a very, again, if you don't have the technology, this is a very great way to account for motion. Which kind of brings me lastly to what I want to talk about, which is these surface mapping systems. So again, these are often add-on systems that you can purchase after the fact. There's now many versions of these. Even when I was redoing these slides from a few years ago, now there's a plethora of these SGRT systems. But effectively, you can install these 3 or some set of cameras, 2 or 3 camera pods. They'll shine some structured light on the patient. They can read out that image, and from the distortion of the speckled light pattern, they can figure out exactly in 3D space to a very high kind of sub-millimeter accuracy what the contour or what that patient's surface looks like in 3 dimensions. So the way that you use it is you export your planned CT contours and your isocenter location to the system, which imports it and then basically calculates your expected position to your current position, and it'll give you basically offsets in all 6 degrees of freedom if you have a couch that can correct for that. But this is really beneficial from many different standpoints. One is that you can basically initially position the patient right off the bat very quickly into the right position, and not just the patient's area that you're looking for, which is usually highlighted like this. You can actually see patients positioned outside of the treatment region. So in this case, you can see these are daily snapshots of a certain patient. You can see the arm has a lot of variability, whereas the breast is usually kind of bang on. This is, has been shown to be very increase your efficiency and kind of get a lot faster through your treatments and through your setup. So this is imaging only, and then when they brought a line RT, you can see that a lot of patients' treatments went much quicker, and the amount of shifting that they do after X-rays went down drastically. But ultimately, the reason why I want to mention it is that this is basically a great motion management system. It achieves both external motion management, it's just positioning in general, and you can use it as a respiratory surrogate. So instead of putting the block onto the patient, you can actually monitor the entire patient's surface in such a way that you can see their respiration as well. And these are being used quite a lot for breath hold treatments, where you can basically coach the patient into breathing. You can see here, very similar. They breathe up into a certain target that you've set. You've imaged it to confirm that all the anatomy matches, and you can link this to the linear accelerator and you can use it to trigger your beam. So we're still kind of getting used to our RGAC systems here at Stanford. We've had them for a little bit, but we kind of use them more seldomly. But basically we love using them for intrafraction monitoring for SBRT. So making sure that once we're aligned, we don't, our patient doesn't shift during these high dose hyperfractionated treatments. Or I'm sure you guys don't have this issue as well, but if we're waiting for the doctor to come review an image, sometimes that can take a long time. And if we have this system monitoring the patient, we can see if the patient's moved since we took the cone beam, or we took some IGRT until the doctor arrives. So there's lots of other areas where this works well. In the past, stereotactic cranial radiosurgery used to look like this with pretty invasive external mobilization. And now you can use the same thing, achieve the same results with, an open-faced mask and this sub-millimeter tracking of the patient. It's been shown a lot of the time it's very successful. There are some limitations that I want to mention before I run out of time is, it only is measuring the surface. So, any of your internal anatomy, you still have to image somehow to get proper anatomical alignment. The area of the body must be uncovered, which is not our sort of standard here. Body habitus is important. Patients need some sort of topography. So doing things for like prostates or like pelvises is difficult because it's pretty round and flat on that area. And to be honest, it's quite different workflow. And so that's why I think for us, there's a pretty slow adaptation of SGRT. It's just a lot of changes, but we're slowly working through there. Okay, I'm going to stop here because I think we're going to run out of time. So maybe if there's some questions, I feel like this.
Yeah, thank you so much, Pьотr. Excellent lecture. That's a great overview. So I hope it gave everyone an idea about motion management and how they can be implemented, let's say in Ukraine as well. So I am opening the floor for questions. If anyone has a question. Maxim?
Yep, thank you so much for presentation. I have a question because you covered 4D CT quite a lot, and I know that currently it's a quite hot topic to use a synthetic CT, at least in a research field. Are you implementing this research at your institution, or are you have any plans about it?
Oh, good question. I don't think we are anywhere close to implementing it for now. I know that a few of the Stanford faculty are working on synthetic CTs for MR motion management. So I think that's coming, but I don't think it's anywhere near the clinic yet. Yeah.
Thank you.
No problem.
But Pьотr, in terms of implementing it in the low middle income countries, I know you worked with Africa. What is the approximate cost, so we get an idea to bring in, let's say, 4D CT into the clinic, to bring RPM into the clinic?
Yeah, good question. To be honest, I feel like, in terms of costs, licensing costs for CT scanners are kind of hard to nail down. They're probably in like the 100,000K range, I would assume.
Mm-hmm.
RPM systems, I think the SGRT systems have a lot of potential because they can kind of do two things. They can, manage your external motion, so you don't have to be as rigorous with your immobilization, and they can kind of be a surrogate for the RPM system. So I feel like that's a good bang for your buck in terms of an investment, and they can always be like vendor agnostic, right? You can take a CRAD system and put it on your Electa machine, or you can put it on your Varian machine. So they're a little bit more adaptable that way. So from an investment standpoint, I think I like the SGRT systems for that.
But it only works for targets that, let's say for breast, right? So that you have surface moving, but let's say for other things, I don't know.
Yeah, but I mean, in terms of like you can use them as an RPM